Thank you, Dr. Burlaka. That was a fantastic talk on a very difficult topic. And with that, we'll have a Q&A session now. And Dr. Levinson will be fielding questions from the chat, and we'll be taking questions from the panelists as well. And I'm going to open up with kind of a dilemma we have to Dr. Molek here. When we send the gene testing, it's positive or negative. It kind of makes our life a bit easy. What do you do when you get the dreaded VUS, or variant of unknown significance? And how often do you follow, and do you do family screening for VUS?
VUS is a dreaded result because you're neither here nor there. And I think it needs a very nuanced approach to interpreting VUS in the context of the patient family. So first thing, we would then go in and look at what was the in silico analysis and what was predicted based on the in silico analysis, whether the protein is disrupted, the function is disrupted. The second is sometimes, and we know that a lot of these variants are private variants, which are just in that individual family. And that's one of the reasons they are of US. We would end up doing variants.
Doctor, I apologize. Could you swap microphones? We can't seem to hear anything coming through that one.
Hello, can you hear me now?
Yes, better.
All right,
Thank you.
right. Sorry about that. So we would pursue VUS resolution program, which a lot of these genetic testing companies offer. And for that, it will require a phenotype established evaluation in the first degree relatives, as well as looking at whether they carry the same VUS. And also if there are any other affected programs, which could be not first degree, could be second degree, or even far off related. We would try to see whether we could try to pursue the variant. And if it segregates with the disease in the family, then we will say that probably there's a more of a certainty that this is the causative one. So I do not ignore VUSs, and I do chase them.
Thank you.
I have a question. Can you hear me? I have a question for you, Arvind. You gave a great talk and a great summary about kind of the history of the development of several therapies in this disease. And all of our diagnosis, after all, is to essentially treat our patients. Anything new coming down the pike for therapies?
Well, the answer to that is not very positive, unfortunately. There's not a lot of new things coming around. I think it's a combination of, at least this is my personal opinion, that the rarity of the disease and investment required to develop new therapies for this. Just to highlight a recent example, we were excited about the PREVENT trial, which was going to be for vascular EDS. Unfortunately, that is on hold right now, and my speculation is it's a lack of funding. Hence, it's important for foundations like Marfan Foundation with Dr. Grima to lead efforts and raise awareness so that we put our efforts into developing new therapies. So, not a great answer, but I remain optimistic.
So I had a question. I guess I'm not sure who wants to take this, but I predominantly see adult patients with maybe mild aortopathy, and I'll be honest, think I've ordered predominantly a genetic test for these patients. And obviously, when it's a severe aortopathy, I will refer them to our aortic surgeons like Dr. Sultan, and honestly, probably ask them whether to decide when to get genetic testing. But I'm worried that I have patients with mitral valve prolapse who I'm missing now have Marfan's disease or other types of aortopathy. And I'm trying to figure out whether the expectation of a standard pediatrician or a standard PCP or a standard cardiologist should know how to diagnose Marfan's or know how to refer to genetics. It's just something that I have trouble sitting with. I'm curious, maybe that side of the room.
When you look at the pediatric world, one of the big source of referral that we have is coming from the general pediatricians because they are worried that the patient has a Marfan phenotype. A lot of times they've heard a murmur and detected there was mitral valve prolapse, and patient gets referred to make sure that there is no underlying connective tissue disorder. So I feel the awareness is important. Can they do the full diagnosis themselves? Probably a little bit more difficult. Even for me, a lot of times I'm not fully comfortable doing the whole phenotyping for connective tissue disorders. I'm a trained cardiologist. A lot of times I would end up utilizing the help of my medical genetic colleagues to make sure that a full phenotype is done at the same time as we are doing the genetic testing.
Yeah, I would agree as well that if it's gotten to the point where you're sending an adult to surgery, I think that makes sense to kind of have that family sent to the genetics team and to kind of look through the family. I hear you sometimes there's a lot of patients with dilated aortas and we're not sure why, and you may not find a genetic reason why, but certainly I think if they're going to surgery or significant aortopathy, it makes sense to have that whole family looked at, starting with the patient who's affected that you're saying. Makes a lot of sense.
And in current guidelines, 70 to plus degree family members should undergo screening, and as well as second degrees, I know where it has been extended to.
And I think go ahead, please.
So a few years ago, we decided to look back at patients we treated for an abdominal aortic aneurysm because we keep seeing that some of them come back with a thoracic aortic aneurysm. And those were seemingly, degenerative AAAs. And we found that about a third of them end up having either a metachronous or synchronous thoracic aneurysm. And while we think of abdominal aortic aneurysm as a degenerative disease and thoracic maybe as a genetic disease. So what are we missing? There's clearly a link between the two, which is not necessarily known in the community. For example, if you try to order a surveillance CT scan of the chest to screen for a thoracic aneurysm, it's often denied by insurance. So what do you think we can do to establish that link?
I think, one of the slides that I had shared when we were trying to figure out how can we minimize the diagnostic gap that we have for thoracic aortic aneurysms, one of the risk factors was if there was a known abdominal aortic aneurysm, those patients should undergo thoracic aortic aneurysm screening clinically. As to insurance would deny, I think that's where there has to be concerted effort, both from the different interest groups, patient interest groups, foundations, medical groups, trying to say that this is a very valid indication. And I think this is going to soon make it into the guidelines. I have not personally gone through the 2022. I'm not sure whether that is including the aortic abdominal aneurysm as one of the indications for, but it will make it in the guidelines soon. I also believe that there's probably a subset of abdominal aortic aneurysm patients where there is a genetic component. It's just that we do not appreciate it. This may not be the Mendelian inheritance. There's certainly risk alleles which have been identified, and it's more of the polygenic inheritance.
I'm also wondering, just to your point, sort of to bring in the imaging concepts of how do we lower barriers to diagnosis. I think right now, treating blood pressure strictly is probably the number one thing that I know that we can do to reduce risk. And so I think for me, thinking about sort of quality improvement initiatives for the treatment often just really focuses now on earlier diagnosis. And so I'm curious maybe to Chris Dybel's point about non-contrast CT scans. Are we vastly underutilizing something like that, which probably insurance companies and the rest of us would probably feel like we could find an aneurysm pretty well on a non-contrast CT?
Yeah, I mean, there's actually been some effort in breast screening. It's been recognized that breast MRI is more sensitive. there's a movement towards abbreviated breast MR protocols, and I think there's, certainly the non-contrast techniques are much quicker, much less risky, whether it's MR or CT, where, we run CT nodule screening clinics. For pulmonary nodules, the lung cancer screening trial data is overwhelmingly in favor of, that being beneficial. So I think, for people with risk factors and other things, there's certainly room to talk about, that type of process.
I thought you made a great point too, Chris, and I'm glad you included it about longitudinal screening. If you find somebody and send them to surgery and have their kids go see Rachel, and Rachel diagnoses aortopathy in a 3-year-old, we don't want that 3-year-old getting a CT for the rest of their life every year. So I thought your point about non-contrast, non-radiation, image gently, right? I thought that was a great point.
I just want to make one comment. I think one of the things that's really important, we talked a little bit about gaps. And it's, when we diagnose patients in childhood and maybe identify families that are at risk, and then still have that gap. You talked about 18 to 25 coming over to the adult congenital, in which I'm like a pseudo-adult congenital at times because of the amount of congenital disease that we see within pregnancy. How can we, thinking about safety and better communication and better care of these patients, how can we close that gap? At our center, I think we do actually a pretty good job because we are in such constant communication about these types of patients. But how that handoff, I think, is when, especially women who are at the childbearing age, when they get to teens and 20s and 30s, where we lose them and don't have eyes on the aorta.
Yeah, I think that's a great question. I think, having referral centers makes a lot of sense, making sure they know there's a medical home, starting the discussion early. So talking about it, I try to have my patients kind of repeat back what their disease is to me. I give them quizzes for next year of what they have and what their problems might be in the future so that, if they're off at college, they can communicate what their issues are and they know their health. So I think empowering the patient, empowering the families, working with, the Marfan Foundation to have families feel more supported and have a better community is one way. But I agree, it's a problem that definitely needs more attention.
Great. Thanks for a great discussion and a great session, everyone. I'm going to wrap up with the plug for the importance of a transition program. Natalie Stokes, one of our cardiologists, is doing a lot of work in sexual and reproductive health in the transition period, and not everybody is comfortable having those discussions. So, and that's why it's important, as Dr. Torok mentioned, start those discussions early and keep it ongoing and have a formal transition program. So again, thank you very much for all the panelists and the speakers. It was a great session. I think we're going to take a short break and 5 minutes and reconvene at 10:20 for the next session. Thank you.